Okay, started your timer and here is your question. Right, so if you have read and understood, considering a clinical examination patient, kindly begin.
I will enter the room, wash my hands, greet the patient. Hello, I'm Dr. Muhammad, I'm the surgical doctor. Today I have been asked to examine your hip joint. Are you okay with that?
Yes.
Thank you. May I confirm your name and age, please?
I'm Smith, 66 years old.
Okay, nice to meet you, Smith. Can you take off your gown, please?
Okay.
Thank you. I'll start by general inspection of the patient. If the patient is walking near side the patient or crutches, then I will ask the patient to roll his short. Can you roll up your short, please? I'll start by local inspection of the hip joint, looking for any deformity or any surgical scars or any muscle wasting. Looking for the gluteus muscles wasting and also quadriceps muscle, and also for any dilated veins. Then I will ask the patient to take few steps. Can you just take few steps for me, please?
Okay.
Looking for any hip tilt or any untitled gait or any Trendelenburg gait. Then
okay.
I would like to do the Trendelenburg test. Can you stand up on one leg for me? I will try to support you.
Okay.
And do for the vice versa for the other limb. Then I will ask the patient to, can you just sit down this couch for me? Do you have any pain?
Not much.
Okay, tell me. I will try to be gentle. If you have any pain, just stop me, okay? I will start by the normal hip joint, start by palpation temperature. Then for tenderness, meanwhile, I will look at the patient's eyes, looking for any greenness. I will start by the pubic tubercle, then the inguinal ligament, then the greater trochanter. Also, I will do the same for the other limb.
Yes.
Then I would like to do the test, which is called Thomas test. I will put my left hand at the lower end of the back of the patient, at the area of the lordosis, and my right hand will be on the patient knee. I will flex the hip joint. Then I will ask the patient to extend his hip joint, looking for any fixed deformity. Then I will do the same for the other. Then I would like to do the active and passive movement. Okay, I will start by the active movement. Can you just flex your hip joint for me, please? Just bring it to your chest.
You'll start with active movements first.
Active, yes.
Okay.
I will ask the patient to bring his knee towards his chest and then bring it back and do for the other. Then I will ask the patient to abduct and abduction and also extension. Then I will do the passive movement at the same ways. Then I would like to measurement the true and the apparent leg length discrepancy. The true from the greater trochanter to the medial malleolus, and the apparent from the umbilicus to the medial malleolus. And also, I would like to do the test for the Gilead's test. I will ask the patient to flex his knee joint, then the measurement of the femur. And thanks the patient. Okay, thank you.
And offer to help the patient rest
Yes,
up, or patient
to
can rest up itself. Okay, you still have 2 minutes. So that's how quickly you did everything. Maybe did you cover everything?
just
Palpation?
yes, I will like to feel the femoral pulse.
Okay, and
And if there is any time, I would like to examine the back of the patient and do the lower limb neurovascular examination.
okay, joint above and joint below. All right. Can you please summarize your examination now?
Just today I have been examined 66 years old man who presented with right hip pain. On general inspection, patient has no walking aid or crutches, and patient has maybe he has Trendelberg gait or surgical scars in the joint. And should I just mention things like,
If you're telling me Trendelenburg gait, then you should tell me on examination on which side pelvis was tilting.
yes, if patient is left limb
Yeah,
and
this is right limb,
tilt
right
or
hip.
side,
Yes, if it's
yes,
right
it will
hip.
be the opposite, the contralateral side.
Okay. Yeah.
Yes.
And was there any leg shortening or anything? What was your examination when you were measuring the leg length?
There is no discrepancy.
Very good. Okay. And any difference on active and passive movements that you did?
Yes, there will be decreased active and passive movement on the affected side.
Okay.
So this patient will be on the right side.
Okay. Right. So can you please tell me, according to your examination, what are the differential diagnoses that you consider?
Patient might have osteoarthritis.
Okay.
Or rheumatoid arthritis.
Yes.
And maybe traumatic hip joint, traumatic osteoarthritis.
Okay. How would you investigate this patient?
First, I would like to do the protein investigation, CBC, retroid RFT, and inflammatory marker ESR and C-reactive protein. Then I will go for hip X-ray.
Okay, and
if
required,
serious injury, yes, MRI.
Maybe MRI, very good.
Yes.
What are the management alternatives or options that can be offered to this patient?
First, there will be conservative management,
Very good.
regular exercise, and such as cycling, as patient might have osteoarthritis.
Okay, pain evaluation.
Yes, analgesics such as steroid, or maybe patient might need injection such as steroid injection. If there is failure of treatment, then I will go for arthroplasty.
Okay, and maybe lifestyle modification as well.
Yes.
Walking, exercise, diet, weight loss, etc. Okay. And if it fails, then maybe more invasive one. Okay, 40 seconds are still left. What else I can ask you? Right. That's about it. So, was there anything that you missed?
Just I want to say this patient, as in Bazit note, it's written that it will be actor.
Yeah.
And yes, the patient will have osteoarthritis.
Osteoarthritis, yes. And besides,
patient also will have history of surgery, so it will have surgical scars in his right hip joint, and so there is a positive left Trendelberg gait and positive Trendelberg test on the left side.
Yeah.
And 6 deformity, yes, positive stomach test will be on the left side, and surgical scars on the right hip joint. So patient might have superior gluteal nerve injury on the right side, on the operated side. Yes.
Yeah.
This is as written in the so stem will be like that.
Stem will be like that, yes. Right. Anyone else want to add anything or comment on anything?
It's not about commenting, but there's something I want to know. So for the active movement,
Yes.
we can only ask the patient to make only flexion and extension for active movement. Is that right?
Okay.
Yes.
And are there any other movements which can be done?
Adduction and
Abduction and
abduction.
adduction. Yes.
Yeah.
These are also you can ask.
But for extension, I think it would be a little bit difficult to give comments.
Yeah, you
For
will ask the
extension.
patient to tilt to
No,
his
patient,
left side or
he
right
should
side.
ask the, hello,
Yeah.
Yes. Please one by one. Yes. Yes.
he should ask the patient to lie on her or his belly.
Okay.
So he can examine the examination part of the examination.
All right. And for the internal and external rotation, what should we do?
For
For-
external
yeah.
and internal rotation, you have to first flex the knee, then internal rotation, and then first of all internal rotate and then external rotation.
Yeah. Yeah, I know how to perform passive movement for internal and external, but I don't know how to give comment for active movement.
Active
For,
movement. Once
for
you are doing it. Yes, please.
For active movement, you can say the patient that if you do have any pain, then you can command him that would you please flex your bend your knee up to the chest as far as you can. Then when he extend his knee or leg or knee, then it is the extension movement. And the abduction and adduction, that time you can say that would you please turn your right leg to the left side and left leg and towards the outside, something like that.
Bending the knee and then asking to straighten it. I think it will be Thomas test for him.
Sorry.
Yeah. Yeah.
Hello.
Yeah.
Yes.
I don't understand whatever is saying. Last name, what you say?
Dr. Cynthia, repeat, please.
You mentioned that for giving comment on passive movement or active movement or internal and external rotation.
Yes, I said about the active movement.
Yeah, you mentioned that the patient has to flex the knee and then straighten it. So, but if the patient does that way, it will be Thomas test.
In case of Thomas test, you can say the patient now, first of all, you should take the permission to place your hand over the back of the patient. Then you can say that now I'm going to place my hand on your back. Is that all right? Then you can say now I'm bend your knee. Do you have any pain right now?
Yeah.
Am I right, ma'am?
Yeah, you're right about
yes.
Thomas test. Yeah.
Yes.
Good. Thank you.
Welcome, ma'am.
Started the timer and here is your question. Right, so if you have read and understood considering these communication skills, patients, kindly begin.
Could you please give me a few more minutes?
Okay. Okay, continue.
Hello.
Hello.
Hi, I'm Dr. Mo, one of the surgical doctors in this department. So am I talking to the surgical consultant on call today?
Yes, I am with you.
Oh, yeah. Hi, doctor. Yes, I'm going to inform you about a patient who wants to discharge against the Medicaid advice.
Okay, summarize the case.
Okay, there's a fragile elderly lady who has another underlying COPD and mild ventricular failure. She has undergone mastectomy and axillary clearance for her breast cancer. Now she is on her second post-operative. Now her daughter wants to take her home. I have convinced her to stay at the hospital, but it has been 20 minutes, but it didn't work.
Has the patient made her own decision?
Yeah, the patient is the patient's vitals are fine, and he can make a decision, and she is competent.
Do you check the patient?
Yes, I talked. I've checked the patient.
What do you think has happened to this patient?
So this is why I want the patient to continue staying at the hospital. It might be due to delayed hemorrhage from the wound and the drain.
What type of hemorrhage do you think?
It's likely to be secondary hemorrhage.
Is the patient sufficient alert to make her consent?
Yes, the patient can understand all the information I've given. Then she can weigh the risks and benefit. Sorry, all about. She can communicate and summarize all the things I said to her.
What will be your plans of action to this complication?
For this patient, it will be the best for her to be under observation at the hospital in case the swelling grows and the drain volume gets increasing. She might need exploratory surgery.
Will you do if they were insisting to go home? What will you do?
If she insisted to go home, she will need to sign a legal form for her discharge against medical advice. She have to continue all the risks she can face at home, and she have to understand all the red flags and the danger signs, such as increasing swelling, dizziness, drowsiness, and increasing pain. And in that case, she have to seek medical attention immediately. If she understands all those information, she have to sign it and go home.
Will you remove the drain before discharge?
No, the drain won't be removed. I will contact the GP doctor and to arrange a district nurse for her to take care of the wound and the drain.
So will take care of her at home. Who?
Her daughter will be taking care of home, but there's a problem that her daughter is not at home all the time. This is why I'm afraid.
Will you contact with her GP?
Yes, I would call her GP.
And the
What
social
will
services as
you
well.
mean?
Sorry.
Sorry. Okay. What will you mention in it?
I will mention that all about the swelling, and there is a possibility of bleeding from her wound, and to take care to have a review on that wound and also on the drain as well.
Okay, thank you.
Okay. How would
Is
this end?
is there anything to add, doctor?
No, thank you.
Sorry, ma'am, I don't know how to end this up.
How should this
Summarize
end?
it.
Yes. Did you complete
So,
all the
this is,
features? Yes, please.
There's a fragile elderly lady with a swelling in her after
This
on the
summary
second day.
should be how should this summary be? Not not exactly the way you presented in the beginning. Okay, tell me the second summary in the way it should have been. Yes.
I have no idea.
So there was this ISBAR. So introduction, you identified, situation you described, background you told, your assessment you told, and then what are the requirements that you have to summarize. What are the requirements consultant has told you in the discussion? Because you still have 2 minutes. Your discussion with your consultant was not enough.
For the requirement is the patient has to understand all the risks she can face at home, and then sign the form and to seek medical sign the form and go home and seek medical attention as soon as possible if she sees danger signs that I have mentioned before.
Okay. Yes. And one more question a consultant could have asked: when did you do the blood tests? If patient is anemic, or is patient is actively bleeding, or how much there is in the drain?
If there is the information on the notes, I will tell it according to the notes. Yeah.
Yeah, but it's not. Then what would you say? Is patient actively bleeding? How much there is in the drain? So what would you say? If when were the investigations done last time, or when were done recently?
It was done yesterday, and
Was it?
hemoglobin
was done before surgery, but then you would say you'll confirm and you'll get back.
Okay.
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 Once you are saying you'll talk to GP, you have to talk to the social services as well, because doctor is working and living 20 miles away from the mother. Mother will be totally all alone, right? So you have to arrange that as well. And what are the risk factors or complications that you have told? What are the warning signs that you've given to the patient?
The risk factors are increasing size of the swelling, increasing pain, fever, something coming out from the wound.
Yes. And how patient can get the drain out? What instructions have you given according to? Like after how long, after how many days? What instruction? Second post-op day. So what instruction have you given on that? Okay, bell is gone.
Yeah.
I'll give you a quick summary, quick feedback. You started off very well, but then I don't know, you got confused when consultant asked you if patient was able to make her own decision. You just answered in one line. You could have added one or two sentences there that you were talking to the patient, you have informed the patient about the risks, and then you have asked the patient to tell you back all the information that you have given, and you are in that position to conclude that no, patient is kind of being bullied, but then patient is in a capacity to make her own decision. And then in one question, when he asked you if what do you think has happened to the patient, you I think only told about the hemorrhage, reactionary hemorrhage, secondary hemorrhage, etc. But then you can also say that you will consider the presence of DVT or the pulmonary embolism, as patient is having shortness of breath and there is axillary swelling as well. So 2-3 more things you could have added. And and then there was this in the presence of this fresh blood in the drain and the swelling in the axilla. So this you could have added. Yeah, even when the plan of action consultant asks you, you could even say that, okay, to rule out DVT or pulmonary embolism, you'll go for the chest X-ray CTPA. So
Yes.
that way, yeah, those 2 minutes, that extra. And then you can also say that you'll discuss with the medical registrar and you'll arrange for the chest physiotherapist. So the chest physio can also be done while patient is at home. So these are the extra things that you could have added in your conversation. Like here, examiner is asking one question and then you should answer in 2 or 3 sentences. So the complete management you are giving, not just in bits and pieces. So according to me, I think you need to
Yes, ma'am.
practice more on communication skills.
Yeah. Yes, ma'am. Thank you.
Thank you.
Okay, ma'am.
Here is your question. Now it's better. Thank you so much. Yes. Right. So if you have read and understood, considering it clinical examination station, kindly begin.
I will enter the room. I will
Yes.
wash my hands.
Yes.
I will introduce myself. My name is Dr. Nwachukwu Chukwunonso Daniel. I am one of the surgical candidates for this exam. May I confirm your name and age, please, ma'am?
I'm Tina, 40 years old.
Okay, Tina. Thank you so much. I've been asked to examine your back, your spine, and
Yes.
it would involve my looking, feeling, and also watching you move. And it also involve my special test on both your back and your legs, as on your 2 legs as well. And I would, is that okay by you, Tina? Can I go ahead, Tina?
Okay.
At this point, I would also ask for a chaperone.
Chaperone. Very good.
And,
Very good. Yes. You will be
and then
given the chaperone. Continue, please.
Then I also want to expose my patient,
Yes.
both her trunks and then both her lower limb, and then
Yes.
considering her dignity and
Yes.
integrity, I will
Yes.
also be careful so as to preserve her dignity and integrity.
And she
So
can keep the
my
undergarments
examination will
on. Yes. Okay. Continue.
yes, she can give it. So I would then start my examination by watching my patient walk. I will
Yes.
observe if she uses a walking aid, and then I also observe her gait. I also
Yes.
check for if she has any scars, muscle wasting, scoliosis, and also abnormal curvatures.
Okay.
Then I would then go to the back of my patient. I would then palpate along the midline, along her spinal processes, feeling for any pain and tenderness along that line.
And temperature.
I also palpate
Yes.
her and temperature as well.
Yes. Yes.
Then I also palpate her paraspinal muscles.
Okay.
Then I would then go to movement. I'll first of all check her cervical spine, where I will check for flexion. When I tell her, then I also check for extension. I also tell her to turn her head around. Then I will try as much as possible to communicate with her and then direct her on the steps I want her to take. Then I also go to the flexion when I tell her to bend her for the lumbar spine, and then extension. Then I also tell her to rotate when I will be testing for thoracic spine. First, I will do active rotation first before I do
Very
passive
good.
rotation.
Yes. Yes.
Then I will then tell my patient to lie down. Then I will start my special test. Tina, I will be so careful so as not to inflict any pain on you, and I'll be as gentle as possible. If I inflict any pain, please let me know. Then
Okay.
I will go to the straight leg raise, where she will be positioned supine. I will then hold the ankle and then raise the leg. Then when the hip is flexed, then I will then dorsiflex the foot. On the left, I will feel, if it is positive, she will experience pain at the posterior thigh or buttocks. Then I will do the wide lying down. I'll tell the patient to turn prone. Then I will then flex the knee and extend the hip, and also plantar flex the foot. Then when there is pain felt in the thigh or inguinal region, is a positive test for the femoral stretch test. Then I will tell my patient to stand up when I would identify the posterior superior iliac spine, and then I will mark the skin in the midline 5 cm. In the midline 5 cm below the posterior superior iliac spine,
Good.
and 10 cm above the posterior superior iliac spine. Then I will then measure the distance, which will be about 15 cm. Then I will tell the patient to touch her toes, which will signify a full lumbar flexion. Then I will measure the distance between the two marks, which I expect it to be more than 20 cm.
Yes.
Which I expect it to be more than 20 cm. But in the index patient, it can be reduced. Then I also start, then I'll tell my patient to lie down. Then I'll explain to her that I want to do a peripheral neurological examination of both lower limb. That would include checking for the tone. I would then do a leg roll. I would then roll the patient's both legs and then watch the foot. The foot shouldn't flop independently of the leg. Then I would then lift the leg off the bed at the knee joint, and the heel should remain in contact with the bed. Then I also do ankle Clonus, whereby I will position the patient's leg so that the knee and the ankle is 90 degrees flexed, and then rapidly dorsiflex. Now, Clonus is felt by rhythmic beats of dorsiflexion and plantar flexion for about more than 5. Then I will then assess for power. I will assess for power across the various joints, which includes the hip, the knee, the ankle, and then the big toe. Then for the hip, I will then start with a passive movement first, and then I will start with a active movement first, then after active movement, passive movement.
Yes.
For the hip, I will tell the patient to raise your leg up the foot, and then I'll try to push it down. Then I also check for extension as well. Then I'll check for the knee, and then I also check for the ankle and then the big toe, and also do my coordination. To complete my examination, I'll want to do a knee jerk and an ankle jerk, and also check for the dorsal column, and then I also check for light touch and pinprick. Okay, then I want to summarize my case.
Yes, kindly summarize your examination. Thank you.
Okay, I examined a 40-year-old waitress,
yes,
who presented with a low back pain,
yes,
and which radiates to the left leg. The pain has a positive stretch leg raise reflex. It also has there were tenderness along the left thigh.
okay.
My diagnosis for this patient is possible lumbar spondylosis.
Okay, what are the differential diagnoses that you'll consider for her?
For my patient, I'll also be considering in this case, I'll also be considering for
maybe spinal
possible spinal canal stenosis. Spinal canal stenosis. And it's possible that she can also have a disc herniation between L4
Very
L5.
Good. Yes.
Then,
one more, maybe you can add.
She can also have a peripheral neuropathy, possibly diabetes mellitus.
Okay. How would you confirm your diagnosis? What are the investigations that you'll ask for?
I will want to do an imaging an imaging of the lumbosacral spine, whereby
Yes.
I'll do an X-ray of the lumbosacral spine.
Yes.
And I also want to do an MRI of the lumbosacral
Lumbosacral.
spine as well.
Okay, what are the treatment options that can be offered to this patient?
The treatment options which I would offer to this patient would include, number one, conservative management. By conservative management, I would cancel my patient reduction in weight, and then maybe job modification, and also try to change in lifestyle, which would help. Then
Okay.
if the conservative management does not work,
Fails. Yes.
then possibly I would cancel on possible surgical intervention, which could include a laminectomy or a discectomy.
Okay, good, very good. Thank you. I think you covered everything and it was good. Thank you. Started your timer and here is your question. Right. If you have read and understood considering a critical care scenario, kindly tell me, how would you manage this patient now?
I will manage the patient according to the protocol.
Okay.
I will start with the, as the patient can talk, so the patient's airway is clear, then I will check the breathing and I will give oxygen by it's a tight fitting, non-rebreathable mask, and will assess the saturation. And if not improving, then I will call the ITU or anesthetist. Then I will assess the patient and manage the circulation by opening two wide bore IV cannula and send the blood for grouping, cross matching, and ABG, and start fluid. And will assess the patient circulation by seeing his capillary refill and urine output, pulse, and blood pressure. Then I will, at the same time, I will send for other investigations like ABG, ECG, CTPA, and chest X-ray. Then if the patient is stable, then and there is a massive pulmonary embolism, then I'll start low molecular weight heparin according to the trust protocol. If the patient is unstable and there is massive pulmonary embolism, then I will give low molecular weight heparin at the dose of 1 milligram per kg twice daily, and catheter directed surgical embolectomy. And if there is massive pulmonary embolism and there is low risk of bleeding, then I will go for total plasminogen activator. And if there is high risk of bleeding, then I will go for surgical embolectomy and catheter directed.
While managing, you realize patient is not hemodynamically stable. How would you manage now? What measures would you do?
If the patient is not hemodynamically stable, then I will go for the surgical embolectomy and catheter directed thrombolysis.
Which agent would you use and in which dose?
I will use a therapeutic dose of low molecular weight 1 milligram per kg and twice daily. And prophylactic dose I will use according to the weight. If the weight is 50 milligram, then I will use.
Okay, can you please tell me what are the differential diagnoses that you'll be considering now for this patient?
As the patient is old, I can consider first it may be a case of MI or and post-operative day 1, there will be a chance of basal atelectasis, and there will be heart failure due to fluid overload, and there may be anxiety, there may be pleurisy.
What
bronchitis.
investigations would you ask to be carried out immediately?
I will carry it out immediately. CTPA, which is the gold standard. Other than that, I will do chest X-ray, ECG, and complete blood count, D-dimer, and a ventilation perfusion mismatch, and
Okay.
ABG also.
Can you tell me how, if just suppose patient is in post-op 1 day and patient has is suspicious of having pulmonary embolism, how would you take care of thrombolysis of this patient? The patient is hemodynamically unstable.
There are some medical and surgical intervention, and at first I will do CPR by giving by putting a thumb in precordial region, and if patient is hemodynamic, then I will give some thrombolytic agent like streptokinase or urokinase,
Okay.
and I will give anticoagulating agent, heparin or warfarin for the long duration.
Which
And
one would you choose? Heparin or warfarin? You can't give both. Which one would you choose?
as the patient is old and the old patient has renal function is good, then I will renal function is not good, then I will choose heparin.
If renal function is good, you'll choose heparin, or if renal
Yes.
function is not good, then you'll choose heparin. What did you say?
Want to say if the renal function is not good, then I will choose heparin.
Is not good, then you'll choose heparin.
Yeah.
Which heparin?
A slow molecular weight heparin, ma'am.
In which dose? What is the clinical name of it?
It's Clexane and 1
Yeah.
1 milligram per kg for twice daily, and it will be a prophylactic dose and therapeutic dose, and in yes.
Would you be able to tell me the pathophysiology behind pulmonary embolism? How does it occur?
If there is if there is a pulmonary artery obstruction, like
Yes,
embolus
yes.
impact in one of the branch,
Yes.
there is a decreased renal ventricular outflow tract. And
Okay.
beside, there will be released some mediators, vasoactive mediators from the platelet, which activate the thrombus formation. And
Yes.
these both factor causes increase the pulmonary vascular resistance,
Yes.
and this resistance decrease the cardiac output, and they increase the ventricular afterload, and it will appear as myocardial increase oxygen demand and increase heart pump, and there will be increased pulse rate.
How this pulmonary embolism affects at lung level or alveolar level?
Ma'am, as there is heart cannot pump blood,
Yes.
so there is increased load in the pulmonary artery, increased pulmonary resistance. So there is decreased
Flow to the lungs.
flow to the lungs, and there is ventilation perfusion mismatch.
Yes.
So
and
there is
that
increased pulmonary
increases-
hypertension.
Yes, increases
Increased pulmonary-
physiological dead space, and that leads to
Yeah.
bronchospasm and
Bronchospasm.
Yes, very good. Okay, and that leads
Hypoxia.
to hypoxia and very good.
Yes.
Hypocarbia, etc. Very good. Okay, can you please name few risk factors which can develop or which can lead to DVT formation?
The patient prolonged immobilization, patient or recent pelvic surgery patient,
Okay.
and some
good.
medical condition like malignancy, dehydration,
Very
and
good.
vascular injury, and some hematological cause like phospholipid protein C and S deficiency, antithrombin 3 deficiency, and the patient who was taking OCP on hormone replacement therapy,
In
they
that,
will.
yes, thank you. In that situation, what are the measures, preventive measures that can be taken or can be advised?
There can be
to the
given
patient?
preoperative, paraoperative, and postoperative. Preoperatively, we will ask the patient to take heparin subcutaneous infusion, and we will use a thrombo stocking. And paraoperatively, we can use intermittent pneumatic compression. And postoperatively, I will advise the patient early mobilization and use intracaval device, some intracaval device.
Yeah, only if
transfer.
you suspect repetitive pulmonary embolism. Okay, very good. All right. And now that concept that you have, which one to give? If patients' renal functions are not stable or disrupted, or then which heparin to give? Not low molecular weight heparin one.
Ma'am, can you repeat the question?
Yes, exactly the question I was asking you during this one. Which heparin to give? If patients' renal function tests are not correct or stable or
yes,
or
renal
poor.
function is not. Ma'am, what I know that if renal function is not good, then we will use low molecular weight heparin.
Are you sure about this?
Because heparin can be monitored in old patients, but that's what I know, ma'am. If anyone can give any suggestion, I don't know.
Yes, I want them to give me.
Unfractioned heparin.
Which one?
Unfractioned heparin.
Yes, yes.
Unfractioned.
Yes.
Okay.
Yes. Because if patient is, doesn't matter, even if patient is old, but patient's renal function tests are good, then you can give low molecular weight heparin. But if not, then the other one. That's the rule. Then you can't take the risk. So other than this basic concept that you didn't have right, all everything else was correct. Good, thank you. So I've started your timer, and here is your question. Right. So if you have read and understood, considering that history taking station, kindly begin.
I am Dr. Khawar Rahman. I am a surgical specialist. I want to take your history. Please tell me, what is your name?
Hello, I'm Tom.
Hello.
I'm 64
What is
years
your
old.
name?
Yes, I'm Tom, 64 years old.
Yes, and I will check your date of birth. I will check your date of birth. I have checked it. Then please tell me, for me, that what is your problem?
Yes, doctor, I have a bleeding coming from my pancreas.
For how much duration? How duration? Please tell me the duration.
Yeah, it's like about 6 months.
Either it is daily or intermittent.
Yes, it does go and come.
It is chronic. It comes daily.
Yes,
Is it mixed with a stool, or what is the pattern? Either it comes before, after, or mixed with a stool.
no, doctor, it's just the blood.
What is the color of the blood? Like cutting the finger and red blood or black blood?
Yes, doctor, it's like a fresh blood.
Fresh blood. Clots comes.
No, doctor.
Is blood? How much blood it comes? It is a spoonful or half teacup.
Like a teaspoon.
Is it in splash or in drop wise?
Yes,
Okay. Is it associated with pain?
yes, sometimes I feel like I have pain in my tummy.
Okay. How is your bowels condition? It is constipation or diarrhea. Which type of bowel habit do you have daily?
Yes, doctor,
Go to
sometimes I feel like I have diarrhea, and sometimes I feel like I have constipation. Like 2 days ago, I felt like I have constipation.
how is your appetite?
Oh, doctor, I don't eat anything like usual. Like I have lost of my appetite almost.
Okay. And do you have any vomiting?
No, doctor.
Do you have any upper abdominal pain and indigestion, dyspepsia?
No, doctor.
No acidity. Okay. Do you have abdominal pain?
Yes, sometimes I feel like I have a pain in my tummy.
Okay. Is it persist? Is it associated during defecation, or it is most of the time it is persist?
It does go and come.
Do you have any complete obstruction of the bowel, like complete constipation or abdominal distension? Tummy,
No,
your
doctor.
tummy is. Do you have loose cloths? Do you observe that your cloths are loose?
No.
No. Okay. Do you have any family member who have some bowel problem?
Yes, my father has the same condition.
Any cancer in your family?
Yes, my father has the same condition and he died, fortunately.
Okay. Are you using a medication for hypertension?
Yes, I use medication, but I don't know the name exactly.
Okay. Any other problem do you have?
No, doctor.
Okay. And how many cigarettes do you smoke?
So about 5 to 6 packs per day.
Any other habits do you have, like alcohol and any other?
Yes, I drink alcohol occasionally.
Okay. Do you have any past medical operation? And
No, doctor.
okay, I have completed my history.
Okay, thank
You
you.
still have 1 minute and 22 seconds left.
Okay.
What have you missed?
Any other chest problem do you have? Any other chest problems? Any other?
No, doctor.
And any other skin changes? Any other jaundice do you have?
No.
No. Or any abdominal mass do you feel?
No.
Fever?
Social history, maybe you can ask. And
Yeah.
then ICE, idea, concern, and expectation, and then systemic review.
Yes,
That's
systemic
maybe
review.
you've done already. ICE, maybe, what is your idea of your condition? And what do you expect us to do?
Yes. Now I summarize the case, madam.
You still have 1 minute. I said you can ask about the eyes and
Do you have
proteins.
any yellow eyes? Yellow eyes?
No, doctor.
Okay. And no yellow eyes, no yellow discoloration of the skin, and
All right.
yes.
Okay. Now you can summarize your history technique.
This 64-year-old gentleman has abdominal pain and constipation for 2 days, and he has many episodes of fresh red blood, which is not associated with pain during defecation, but may sometime pain in the abdomen was there. He also has weight loss and there is an altered bowel habit. Sometimes he has constipation, sometimes he have diarrhea. His weight is lost, and there is no jaundice, and his family history is positive, as his father has the same problem, and he died due to some cancer. That is the summarization.
Okay.
He's
So
a
what are
smoker.
your differential diagnosis for this patient?
My differential diagnosis is malignancies, colon cancer or rectal cancer, and he also may be a case of diverticulosis, and
Okay.
and there is some maybe infective diarrhea and
What are
amoebiasis.
the most important investigations that you'll ask for this patient?
The most important investigation is colonoscopy. I will do it.
Right away?
Uh,
Would there be
no,
any
first of
blood work? Yes.
So, the most if I will go on protocol, then first of all I will do the blood CP and carcinoembryonic antigen serum LFTs and X-ray chest and X-ray abdomen, that there may be some obstruction, and the serum urea creatinine and electrolyte. Then I will go to colonoscopy or sigmoidoscopy.
Okay. Okay. Right.
Then CT scan. Then after that, I will go CT scan, and if there is a mass,
Why
then I will
CT scan?
biopsy.
Why would you do CT scan?
If you tell me that on colonoscopy, if I find that there is a colonic cancer, then I will do the CT scan to check the metastasis of the chest and abdomen. CT scan.
In case you'll suspect malignancy. Okay, good.
Yes, if I found a mass.
Right. Okay.
If there is a rectal cancer, then I will do the MRI or transluminal ultrasound can be done.
Yes.
So
So
it depends on my colonoscopic finding.
yes, all right. But this is not what you'll do. In here, once you're preparing for an examination for England or Ireland, what they want that once you're taking the history and then once you presented yourself that who you are, and then you ask for the patient to confirm patient's identity and why a patient is here, and you started asking and patient told you why patient is here, then you should listen and you say, I'm really sorry to hear this. Like, you have to acknowledge the patient, that patient's pain or patient's bleeding in stool is not a good thing, and you're feeling sorry for the patient. So here, every time once you ask if you're passing any blood, really, I'm sorry to know that. I can imagine how painful that could be. So in this scenario, when you're taking history, your questions were very relevant, but it was like monotonous. It's not how we do in clinics. Even here in the West, they ask question and then they show empathy. They say a lot of these sort of words, and at the end, there is one protocol that you ask the question, what is your idea of your condition? And then patient will say, oh, maybe I'm also having cancer like my father. So what is your expectation from us? Then patient will say, I expect that you'll diagnose me and you'll get me better. So what are the, then there is then concerns. Okay, what is your biggest concern? I'm losing weight, so maybe I think that I'm also having cancer and I'll die. So these three questions are also very important. At the end, if you could not complete your history, and at the end still there was time, then you'll say, okay, if time would have allowed me, I would have asked the questions that you missed, then you'll mention those, and then your examination. So today was the first time you did. You'll go back, you'll listen, and then you'll, I'll request you that if you will Google in the YouTube any other bleeding PR which has been done before you, and then if you'll spend just a few moments listening to their history, and then you'll realize they'll be of variable level. Some will be good, some will be bad, but there'll be variation. You'll realize maybe you'll come across someone who would have taken very nice history, but then history taking is very difficult to complete at any given time. And maybe no one has taken a good history, but yeah, just the empathy for today.
Okay, madam, I will recheck it.
Thanks.
Thank you. Madam, the last three things you told me, that what is the patient expectation and what are the other two
Idea.
things? What are
Idea,
Yeah.
concern, and expectation. They call it
idea,
ICE.
concern? Yes,
It's
idea,
given in
concern.
all the traditional notes. It's given.
Yes,
Idea,
ma'am.
concern,
Idea.
and expectation. You have to ask.
Yes,
Is it
yes,
must?
understand.
Thanks.
Thank you.